Hello and welcome back to Rising Stars episode number 8, and welcome back to all our regular members. Uh, Today we're going to be discussing something very different: global ophthalmology. What does it mean to us? But before we move into that, let me explain how all of this works. Each episode we have one Rising Stars, and today's is a very special one. Surrounding them will be three special celebrity panelists. These celebrities are the ones we've cherished all over our careers. They're mentors, they're stars in the field of ophthalmology. This is a very interactive discussion. It's a very interactive series, The Rising Stars. So any audience member watching can throw questions in our chat window on YouTube. We are live on risingistars.com and YouTube channel. The event can be watched on our website. Also watch out for our social media, where we release educational tips and snippets for all episodes. I'd like to first of all thank all of you guys personally for tuning in, and thank you for sponsors for making this happen. Right now, I'm going to give one of the toughest jobs to Bill Trattler to introduce the celebrity panelists and the speaker. Bill, all over to you.
Beautiful. Well, it's my pleasure. It's exciting to be here with everybody, and I'm excited to introduce our celebrity panelists and, of course, our rising star. And we're going to start off with Dr. Guy Kezirian. As you can see, he went to medical school at Brown University and then did his ophthalmology residency at Lenox Hill Hospital. Then he did a fellowship, which I didn't realize until I worked on this a little bit, is that he did a fellowship in oculoplastics. But obviously, he's very involved in refractive surgery, probably for most of his career. He also is very involved in business, and he got his executive MBA at the Kellogg School of Management at Northwestern University. And he's just one of the leaders, not only in ophthalmology, but also in business development and trying to help doctors and ophthalmologists and medical doctors understand more about business. You can see his current positions here listed. He's CEO of Surgery Vision. He's CEO of Physicians Equity Holding. He's also founder of the Refractive Surgery Alliance, which I feel very fortunate to be a part of. He's also chairman of the World College of Refractive Surgery, which I'm also very fortunate to be a part of, and I think is a very important initiative. He's a board member of the Himalayan Cataract Project and chairman of Physician CEO. And then we ask everybody to share a fun fact. And Guy, why don't you share your fun fact or interesting fact or something just about yourself that really shares who you are? I'll put it up here.
Well, that's what I do in terms of trying to bring people together and create value. If you want a fun fact, I used to be a commercial pilot, but I stopped doing that.
Wait. Oh my gosh, I did not know that. That's actually a very fun fact. But no, you've done such a good job with all these organizations of bringing people together and collaborating. So we really appreciate you, and we really love the fact that you're part of this program tonight.
Thank you, Bill.
Next, I'm going to introduce our second celebrity panelist. So the question to we'll ask Dr. Ball, where do you think this photo was taken?
I'm going to say somewhere in Nepal. I feel like Everest wouldn't be out of question, but one of the mega summits.
Dr. Tabin, where was this taken?
That was 1988 on the summit of Mount Everest.
Wow, it's very cool. I found this photo. I just love this photo. So I just had to share that. And this is Dr. Tabin in civilian clothes. He's did his MA in philosophy at Oxford University, and then went to medical school at Harvard Medical School. This is residency at Brown University, and then did a fellowship in corneal surgery in Melbourne, Australia. And then his current position, he's professor of ophthalmology and global medicine at Stanford University, and he's obviously co-founder and chairman of the Himalayan Cataract Project. Has made such a big impact on so many people globally around the world. And of course, for a fun fact, there are so many fun facts about Dr. Tabin, but I don't know if you could just briefly share something about Wikipedia and bungee jumping, and I don't know, maybe you're involved in that somehow.
Yeah. Well, I was when I was at Oxford, I used to party with a group called the Oxford Dangerous Sports Club, and I was on my way to go on a climbing trip to Irian Jaya, New Guinea. And the leader of the club said, "Oh, you're going to New Guinea? You must try vine jumping." Which actually, a little question for Dr. Ball or for you. The vine jumping was actually a puberty ritual, not in New Guinea, but where was it a puberty ritual? It was in Vanuatu, But in any event, we came up with the idea of urbanizing New Guinea vine jumping. And on April Fool's Day, 1979, we did the world's first ever bungee jump. And then we were asked to recreate it on a TV show called That's Incredible. And for 2 years, the opening segment of the TV show That's Incredible was me in a white tuxedo bungee jumping from the Royal Gorge Bridge in Canyon City, Colorado.
Oh yeah, thank you for sharing that fun fact. It's definitely love that fun fact. I'm sure we'll come back to that at some point. Oh my gosh. And we need to find the rerun, so we can share that as well. Then we have Dr. Audrey Rostov, and don't worry, her fun fact is going to be just as fun, right? But anyway, as you know, Dr. Rostov is actually she's a veteran of Rising Stars in Ophthalmology. So thank you for coming on tonight, and just I know this is an area you love, so thank you for being part of this. So she's obviously she went to Harvard Medical School. Preclinical, and then she went to medical school at Washington University in St. Louis. Did her residency at Washington University in St. Louis, and then she did her fellowship at Minnesota Eye Consultants. She's currently the director. She's a cornea, cataract, and refractive surgeon at Northwest Eye Surgeons in Seattle, Washington. And then for Dr. Rostov's fun fact is, I know Dr. Rostov very well. She does so many fun adventures, but I was trying to figure out, because I know she loves being in winter sports, whether she's a snowboarder or a skier, and maybe you can share your passion and what you love doing the most.
Totally snowboarding. So I think I was holding my son's skis here while he was doing some crazy thing. And then I was just about to, you should never snowboard with a 20-something-year-old, because you end up going down a cliff, ending up on some crazy icy shelf, and then having him point the way down. But yeah, no,
oh, yes.
absolutely snowboarding.
Okay, that's
so
good to know.
No question.
Beautiful. Well, so many fun facts for all our celebrity panelists. Now thank you so much for all of you for being part of this. And now we're gonna jump to to this photo. So it's so easy. All you do is put in each of our celebrity panelists' name in Google, and up pops their involvement in global ophthalmology. And these are just like the first hits you get, are all three of you just making such an impact across the world. So thank you so much for all you do, and I'm really looking forward to tonight's episode. And so with that, we're going to jump to our rising star, Sila Ball. Dr. Ball went to Drexel University for college, and then went to medical school at University of Pennsylvania, and there she also got her Master of Public Health, and she did receive a very important award, the United States Public Health Service Excellence in Public Health Award. Very exciting for that. And then she went on and did her residency at Mass Eye and Ear, and she's currently a fellow at Mass Eye and Ear, focusing in corneal and refractive surgery. And then, so we've had so many fun facts, and of course, Dr. Ball, the fun fact she shared with me, I'm going to post, but there may be even another fun fact if you want to share, Dr. Ball. But the fun fact she shared is that her comfort food is just plain spaghetti with plain yogurt on top, which she felt that some people always got a kick out of, especially because her significant other, I guess, is Italian and loves red sauce. I guess that was kind of the contrast. But do you want to share a little bit more about you and your fun facts, or?
It's so lame compared to all the other ones. I also ski and snowboard, so at least I have that to cling on to, but I was never featured as the first bungee jumper on television, and I never summited Everest. So just some goals for me to strive towards. Of course, my fun fact is food oriented, the central topic in my life.
No, it's definitely great, and congratulations for your career so far. And these are some photos. Do you mind sharing with us how these photos and where you are in all of them?
Yeah, of course. So on the first one on the left, I'm actually the one riding the donkey. My little sister's the one holding the leash. I grew up in the United States, but my family's Turkish American. So I spent all of my summers in a small fishing village in Turkey. And then I went to high school as well in Istanbul. So this picture kind of captures my youth and my childhood. And of course, my sister, who is my best friend and who I love so much. And then the center picture is actually of my mom, who passed away a couple years ago, but who was an English as a second language teacher. and who really instilled in me that the world is one large community made up of smaller but equally important parts. And then top middle is a outreach trip that I did as a resident with one of my greatest mentors, Dr. Roberto Pineda. And then, of course, I couldn't have a slide without my husband. My husband is a ER doctor at Mass General, and we kind of went through this crazy journey of medicine together. And then the bottom picture is the group I work with in Ecuador, and I love all of these people so dearly. So I figured I would include them as well.
Oh my gosh. Wonderful. Well, thank you so much. We're so proud of you, so excited for you, and we're really excited for your presentation. So with that, I'll stop my share, and you get to share your screen. We're excited for your presentation.
Thank you so much. Okay, let me just share my screen. All right, just want to confirm that everyone can see the screen. Everything looks okay.
Yes.
Okay,
That's
great.
good.
So just to reiterate, I'm Sila Ball, and thank you, Bill, again for having me on here. I'm so honored to give this talk on global ophthalmology, and just such an incredible expert panel, and just can't believe that I'm the one talking to you guys about global ophthalmology, since you are all the true stars in this. I have no relevant financial disclosures. Now, I know that the information on this slide is very familiar to our panelists, but it is extremely important for us to define the magnitude of the pathology and the impact it has on our patients, right? 1 billion people live with preventable vision impairment. Cataracts are usually still king in this category. They are 94 million or more, and they're going to continue to increase over the next 40 years. They're followed closely by uncorrected refractive error, and then some smaller buckets of macular degeneration, glaucoma, and then diabetic retinopathy. Now, again, these are global causes of vision impairment. These prevalences are very different in the United States, right? In the United States, macular degeneration really dominates, but still globally, we're thinking about cataracts. But the reality of the impact of vision impairment is more than just these big numbers or some statistical analyses. I don't know if the panelists saw, but a couple of weeks ago, there was this YouTube video that went viral of post-op day 1 cataract surgery reveals. And for good reason. This photo on the left is actually from one of my first trips to Ecuador when I was a medical student. This is a mother and a daughter on post-op day 1. And this woman was so stoic both before and during the surgery. And on post-op day 1, when we took off the shield, of course, she was overcome with emotion, crying, hugging me, hugging the surgeon. We were all just elated. And that emotional impact that we have on our patients is palpable. These concepts are instinctive to us in our deep fear of loss of vision. In fact, Americans ranked fear of vision loss as equal to or worse than losing memory, speech, hearing, or even a limb. And that fear is really supported by data. As ophthalmologists, and especially as global ophthalmologists, we know this, but this is so important that I feel like it is worth repeating over and over, especially in a talk like this. The Global Burden of Disease study in 2017 actually ranked vision impairment 3rd among all impairments for years lived with disability. That's most likely because of the direct impact that vision impairment has on social participation, but also on employment, self-care, and on the impact that it has on those around us. In fact, the quality adjusted life year losses associated with vision impairment are comparable to or higher than other chronic diseases. This includes things like diabetes, asthma, heart disease, stroke, but that impact really extends beyond just that. Individuals with severe vision impairment experience higher rates of violence, higher rates of abuse, and are more likely to get into a motor vehicle collision. Still, as important as I and all the panelists and most likely everyone on this call believe quality of life and impact on social participation are for a human being and for us to be active members of our society, we all know that the number one thing that matters in our globalized world is money, right? Estimates suggest that the potential cost savings in addressing vision impairment are greater than $102 billion. I looked at this systematic review from 2022 that focused on the economics of vision impairment, and in the United States alone, productivity losses ranged between 10 and 14 billion US dollars. Globally, those productivity losses were estimated to be around 380 billion. Unsurprisingly, age and sex-specific analyses showed that the direct cost of blindness was higher for women than in men and rise consistently with increasing age. These are astronomical numbers, right? When I was reading these numbers, I couldn't even wrap my head around them. But this is really an incomplete picture. 2/3 of the studies in this paper were from higher income countries, but we absolutely need more studies on the impact of vision impairment on low and middle income countries, where 80% of the global population and 90% of people with vision impairment live. And that's kind of my segue into my first panelist discussion question for Dr. Kezirian. Just, these are just guides. Please give us whatever background you can on this, but how can we move toward building more economically sustainable systems for addressing vision impairment? And what are some of the barriers to economic sustainability?
So, as you said, that's the fundamental crux of the whole matter. And it is possible to do this. There's, of course, a lot of NGOs that are able to gather funding to support things like Dr. Tabin has done with Dr. Ruitt and building the Toganga Eye Institute in Nepal and institutes all over North Africa, and just amazing work that's being done with NGOs. But I think the future model is for a sustainable economic system. That means, of course, on the basic level, working with ministries of health, working with governments, working with even insurers in different countries, depending on the country and the situation, to create reimbursements that make it affordable to provide the services. But there's a model that I think is just coming to sort of mind. Was a wonderful book called Impact by Sir Ronald Cohen, Cohen, and I highly recommend it. It's a different model for charity. And what it basically says is that when we create value by giving someone sight, of course, as you've already outlined, the increased productivity, they become part of the tax base, they become less likely to cause accidents or be in accidents, they take away from the need for people to take care of them. There's all kinds of economic benefits when we re-sight someone's vision. But as NGOs and even as doctors, we do that, and all that benefit goes to maybe that patient in the community, but there's no feedback on the value created to allow us to do more of that work. The book Impact talks about a different model where you before the work is done, negotiate with the people that will benefit, typically the governments, but it could be NGOs, it could be different organizations that want to sponsor philanthropies or whatever, and say, we're going to re-sight X number of people. We can demonstrate economic return to you, to this government, to this community, whatever it is, of X dollars will occur after this is done. We want to capture back a very small percentage of that, maybe 10% of that, into an escrow fund. We're willing to be monitored and audited. And once we have done the work, then you'll release those escrow funds once we validated the work has been done. And that will return to us more than what it cost us to deliver that and allow us to then do more of that work. So closing the loop on the value creation and the value capture to bring it back to allow the people who want to do the work to do more of the work, I think is going to emerge as the leading model that will largely replace philanthropy. Philanthropy has a great role for, in my mind, of getting things going, but sustainability is the requisite aspect of it to make it really work over time. And I think that this kind of a model is going to allow that to happen. The last comment is that, the pool of funds in philanthropy is only a couple $2 billion a year worldwide. But the pool of funds in invested capital, which would potentially allow you to also draw in money that could be returned back to the people that funded the NGO in the first place, is in the trillions. And so if we could tap into that pool of capital for our work, we would be much better off. I think this is where we're going. And this is called Impact Investing. The book is called Impact. It's by Ronald Cohen.
Incredible. Thank you for that. I'll definitely have to read that book. And I absolutely agree with impact investing. So as you kind of alluded to, ultimately, the goal is really to support global eye care systems that are affordable, accessible, but most important, sustainable. But achieving that goal is still a challenge today. The first challenge, when you get down to the nitty-gritty details, is really in the allocation of surgical and medical care. But then we start to get into challenges related to workforce training and how do we keep these people in countries once they're trained because of brain drain as they start to leave their local communities in search for higher paying jobs. And then finally, financing, we kind of went into that. One other strategy that I learned a lot about during my MPH year and even throughout my residency is kind of the Aravin model with the tiered cost strategy, such that the distribution of services is based on income and socioeconomic status. I actually serve on the board of an organization that provides care to rural communities in the Ecuadorian Andes. And they started out as an international organization, but they later were able to build what was once a small clinic and is now a bigger hospital that has this similar autonomous tiered cost structure that enables them to use donor outreach to serve the poorest individuals, but then they have a small fee scale to support the autonomous clinic. And that brings me to our next panelist discussion, Dr. Rostov. How can we incorporate donor-based systems into local financial models? I know we kind of talked about this a little bit, but if you have any insight, we'd love to hear it.
Yeah, I think part of the focus really is on sustainability. And so both with work with HCP, Cure Blindness, as well as with Sight Life, the focus is really on sustainability. And so it's training surgeons essentially in the local countries to do local surgery. And the other thing, for example, with Sight Life, we built a series of eye banks about 15 years ago when I started work with Sight Life. There really wasn't a sustainable eye banking system in India, and really worked with the getting together the local eye surgeons and eye bank managers and training eye bank managers, but basically training on the local level. And so what you want to do is you want to get input from the people who are actually there. It's one thing to go somewhere, do a bunch of surgery and leave, but when you actually train the trainers, you train the surgeons, you train the, say, mid-level practitioners, you invest in preoperative and postoperative care, then essentially what you're doing is you're building a local system that will be sustainable. And so you can have, you know, donors to your NGOs or to different organizations, you know, local or global. But when you're really investing in the local institutions and in local care to be sustainable, I think that's really the key. The other thing is to really take a look and see, you know, where the blind are, the causes of blindness in the area, and to not only address, you know, training the people to treat the blindness and to cure the blindness, but also to prevent blindness as well. And so blindness prevention programs, again, on the local level, with education, with training community-based healthcare workers, vision eye care workers into early diagnosis and treatment, say, of corneal injuries, can also help to turn off the spigot of corneal blindness, for example. But really looking at the whole ecosystem of what we're doing and really getting that down, drilling down to the local level.
Thank you. And we're definitely going to get into the community-based health services soon, and I'll have some more questions for you, but that was really insightful. So just shifting gears a little here to focus on how we can become effective leaders in global ophthalmology and continue to advocate for advancements in the field. So global ophthalmology, like many specialties in medicine, is an evolving and growing field. What started out as well-intentioned mission trips and surgical care to regions in need has undergone a much-needed revamp to shift the focus toward the development of sustainable health systems, kind of like what we've been discussing already. However, terms like medical mission frame global outreach with a very Western-centric worldview and have deep roots in colonization and religious conquests. Even in international health, which I used to use all the time, tends to really focus on higher income countries, helping lower and middle income countries, without really acknowledging the impact that health has on all nations everywhere. So instead, we should really start to focus on language such as global public health, which implies a transnational approach to health equity and shifts the framing of global health to encompass cross-border and domestic health issues, which are really crucial in our globalized world. Similarly, and these are controversial, but I think it's really important that we get into this, is that dichotomous terms such as developing and developed overgeneralize diverse countries and establish a superiority and inferiority, implying that a country is incomplete. Instead, the shift has been to name the specific country, region, or population that you're working with. And if you're unable, then use broader groups. I personally really like the World Health Organization regions. I also really like using the World Bank's country groups, which are organized by gross national income. Either of these are very widely accepted by both the World Health Organization and the CDC, and are just a way for us to frame this in a more health equity approach. And this brings us to our next panelist discussion, Dr. Tabin. What are some of the biggest challenges you faced as the field of global ophthalmology evolved over the last 20 years? And what do you kind of project to be the biggest challenges in the next decade or so?
Well, thank you very much, Sila, and thanks to Ashwin and everyone for organizing this amazing event and doing an amazing job, Sila. You know, that's such an enormous question, the biggest challenges over 20 years. You know, the first big challenge for the low-income countries has been really creating the reservoir of human resources. And it's not just training ophthalmologists, but also the mid-level healthcare workers, trying to empower primary health workers to recognize and refer eye disease. That's been one of the early challenges. A second early challenge has been equipping and enabling and empowering the local teams once they've developed the skills to continue providing service. The third early challenge has been reaching the unreached. People in positions where they're becoming a physician in a low-income, low-resource country want to have the advantages of the resources of living in a city. They want to have good schools for their children. You need to have good financial remuneration for them, which requires them to be in an urban setting. Meanwhile, a large proportion of the population has remained in a rural, in really dispersed areas. And so it's been a big effort figuring out, how do we reach the unreached? How do we find the people in mountainous Nepal? How do we find the people in remote rural Ethiopia? So that's been the sort of big challenges, has been that initial training of the human resources and figuring out how to reach the populations. One of the big challenges coming on for the next decade or so is that the population is aging very quickly. And there's also a lot of financial incentives to, as the quality gets really great. You know, when we started operating in Nepal, myself and Dr. Ruit, there's an enormous backlog of 250,000 people who are bilaterally blind from cataracts. And so everybody we were operating on at that time was blind. Now we're reaching people in Nepal, and a typical remote cataract outreach with 200 patients may only have 4 or 5 blind people. And a typical patient will be someone who is 20, 30 pseudophakic in the left eye, and they've walked 3 days to have their 20/80 cataract done in the right eye. And the problem is there's a lot of people who have a very substantial income now who aren't blind, who are still working as a tuk-tuk driver. They're still working, running a shop. They're still working, and they have their 20/60, 20/80 cataract, and they want to pay to have their 20/60 cataract done. Their 20/40 cataract, their 20/30 with a PSC, because the quality has become so good in the local populations of surgeons that are in low-income countries. The problem is that there's incentive for them just to operate on the people who can pay. And if you start operating on people who are only blind, right now we have about 16 million people who are bilaterally blind on our planet. But if we operate at 2,200, it's about 60 million people. And we start operating at the level that we typically operate here in America, it's 8 times that number. And so how do we continue to reach the poorest of the poor? So that's one of the other big problems. And how do we create the populations? But I'll just say one thing. It's just such a wonderful field to be in. And for young ophthalmologists, one of the really cool things is each eye we operate on is the most important eye in that person's life. And each person, we have these daunting statistics of 16 million people who are blind. But one of the really great things about ophthalmology is once we operate on them, they're no longer a statistic. They're 100% cured. And then the other big challenge is also refractive care, which you alluded to. But there are so many people who are unable to work in middle age because of presbyopia, and so many children on our planet who unfortunately are not thriving because of myopia. So there's a lot to be done, but it's really wonderful to have rising stars like you, Sila, who are going to take it to the next level.
Thank you, Dr. Tabin. All right, I'm just going to keep moving because of time, but those are all really fundamental. All three of our panelists talked about the fundamental for building a viable health system and for a sustainable health system. And the World Health Organization framework really identifies those 6 essential components: service delivery, healthcare workforce, which both Drs. Tabin and Dr. Rostov talked about, information, products, technologies, financing, and then of course, leadership and governance, which is kind of where we as global ophthalmologists fit in the build. So what are some good practices, some bad practices, and some things that we want to absolutely avoid? I want to start by saying that as we continue to evolve as a field and look for ways to improve, we need to start challenging our past, right? While global health used to look like these short-term unilateral projects, we've already heard from all of our panelists that this type of engagement focuses on donor goals rather than engaging the communities that we're working in and rather than building partnerships. So they often fail to have a sustainable impact. But the biggest mistake that I see in global outreach comes from perpetuating philanthropic colonialism. By continuing to work within the confines of this wealth hierarchy that kind of caused the problems that we're trying to address, we fail to address the root cause of health disparities. And most of the medical missions that were of the past and even of today really don't adequately research the demographics, current events, or even the culture of the communities that they enter. And this can cause more harm than good. This can cause harm in terms of medical mismanagement, poor follow-up, or even things like expired medications and lack of health equity. So how can we strive to be better advocates for global public health in ophthalmology? So we kind of touched on a lot of these already, but sustainable global outreach starts with supporting access to care and helping to strengthen existing infrastructure. This really involves a number of approaches, from engaging international organizations to sustainable partnerships with local providers. But the foundation is really through education and skills transfer, which Dr. Rostov talked a little bit about, in order to further support this transnational state of well-being. And those partnerships are really the most important tenets in global ophthalmology. Now, these can be large-scale partnerships between ministries of health and multilateral bodies like the World Health Organization or the Himalayan Cataract Project, but these can also be smaller partnerships between local and international groups. One area that really does have a lot of potential in global outreach is the development of public-private partnerships, which have resulted in huge successes even in global ophthalmology, right? We have the ivermectin initiative between Merck Pharmaceuticals and multiple local ministries of health, which essentially distributed ivermectin to all of these communities to effectively reduce the impacts of onchocerciasis-related blindness. Dr. Kezirian, I'm sure you've done a lot of work in this and you kind of talked about it already, but what are some of the pearls for navigating such public-private partnerships?
Well, that's a big question, and I think that actually, Dr. Tabin has been a pioneer in this. I would probably say that he'll probably give a much more insightful answer. But everything you just said is true. So, I mean, it's important to particularly engage locally. What HCP does under Geoff's direction is it focuses equally on training, infrastructure and programs. So Geoff will go and do a campaign that does 2,000 cataracts in a week with maybe 4 Ethiopian doctors and himself and a team that they put together, an incredible logistical accomplishment. And that definitely is navigating that process. But the people that are doing those surgeries have been trained through the systems that he's set up. So he's worked with ministries of health. He's built residency programs. We've continued to support them. And there's all kinds of ongoing. It's not like a conversation and you walk away and the job is done. It's a long-term commitment. But that's incredibly satisfying because, and Geoff, you correct me, but I think that since HCP started in Ethiopia about 2012, you've more than doubled, in fact, tripled the number of operating ophthalmologists in Ethiopia. Have you not? Oops.
Yeah, sorry, I was on mute. Yeah, we've actually more than quadrupled the number of operating ophthalmologists, but it's more, really empowering and having them able to continue doing the work. And there's a lot of, I think, more that could be done. The ivermectin story is a really great one. The azithromycin story for trachoma is a good one. The story of the micronutrients for vitamin A deficiency blindness. But there's so much more that could be done. And our pharmaceuticals and our large ophthalmic corporations in America, such as Johnson and Johnson, Alcon, all of them could be doing so much more. And it would be, a complete win-win, because in those sort of corporate situations, as they empower the local doctors, they're also creating a market, so that they're also creating a market for the local doctors to buy pharmaceuticals, supporting the care of the wealthier people in their communities. So it's really a win-win-win. And there's so much more that could be done on these public-private partnerships.
Thank you. That's great insight. It is really truly a win-win. So, our role as global ophthalmologists should really be viewed as temporary, and our role in leadership positions should serve to support the local health system and provide that transfer of knowledge that we've all been talking about, with the ultimate goal of having sustainable local programs within a viable healthcare system. So during medical school, my husband and I worked with an organization in a small village in Uganda. And when we got there, we went to this smaller community that had been plagued with infant mortality related to diarrheal disease. And the year before, this Belgian organization had come out to try to address that issue by building community latrines. And as they were educating the community, they told them, listen, these latrines have to be kept clean. You really need to be careful. And then they left. They came back a year later, latrines completely unused, infant mortality unchanged. And when they asked the leadership what happened, they told them, well, we thought we had to keep these clean, so we were keeping them locked and only using them when someone was really ill or when we really needed it. And I thought that this story, to me, really highlighted the fact that even the most well-intentioned international groups fail to understand the communities that they're trying to help if you're not engaging local leadership. So instead, the organization that Lorenzo, my husband, and I worked with was a grassroots local organization run by one of the local village elders, Augustine, who's pictured here on the right. And Augustine can literally run laps around me despite being decades older than me, and spent his entire life dedicated to the communities that he was working with. And they had their full trust in his recommendations, in his involvement. The picture on the right is me following him around, because it's really the perfect summary of how I spent my entire summer going door to door, working directly where people live, led by people who know exactly what they need. Dr. Rostov, I know that you already alluded to this a lot in our first discussion question, but if you have anything else to add about how we can kind of foster these collaborative relationships between local and international organizations, we've been talking about it a lot already.
Yeah, I guess I would just add or emphasize that one of the main things is to really discuss a needs assessment. And so you need to do a needs assessment and you need to have specific goals for specific areas. And as we've already discussed, talk to the local leadership. Because if you don't have the understanding, and sometimes there's different cultural differences, different languages, and if you don't have, buy-in and really good education by the local community that you're trying to serve, then you're not going to be effective. It reminded me, or your story reminded me of one where there was some group that decided to be helpful for preventing eye injuries and decided to give out sunglasses in the rural area that I was working in, and yet the sunglasses were so coveted, right, that the people didn't use the glasses; they just saved them for special occasions, or they sold them. And so obviously that wasn't a good way of preventing eye injuries. And so you really have to have someone working in the local community do a needs assessment and decide, to start with some basic goals. For example, working with HCP and some other groups in Nepal, working with the village eye care workers and training women who also provide healthcare. They're mostly women who provide healthcare like immunizations, mom-baby care, those sorts of things, and then training them as well in eye care and early diagnosis and treatment of eye injuries. And then having follow-up with these women. So they have continuing education every 6 months, again, by local managers who are also part of the community, and that's really, really important to have a collaborative relationship. And so whoever the organization may be, and that may be on a governmental level combined with philanthropy or whatever it is, but you have to make sure that you're really supporting the local level. And that you're doing it in a way that makes sense in terms of your infrastructure, and that goes again to infrastructure building, so that you can really have a sustainable effect.
Thank you. That really is just the perfect segue into this next discussion point, which is really about community-based service delivery. So community collaborative engagement is really essential to each section of the health system, so that we can address those local community needs, as Dr. Rostov is telling us about. This really involves a 4-pronged approach. These are routine, systematic visitations of all homes, peer-run groups, community health workers, like those mothers that are the women in the community that help mothers with vaccine outreach, and then, of course, health service provision at outreach points. So a hub and spokes model where you have a central base, and then you have all these different groups going out into the community, bringing care closer to where individuals live. But how do we measure our impact? This is really a shared responsibility between both the host and the outreach team. And it involves establishing some outcome measurements, looking at the health impact, and really understanding the greater societal impact of our work. So this is our last individual discussion question. Dr. Tabin, how do we engage local stakeholders and better support local leadership to develop stronger community-based service delivery?
I think one of the big things that hasn't really been mentioned enough is the financial remuneration for the local physicians and for the local nurses. And that's one of the big challenges we have in terms of creating ongoing, sustaining care in the less well-off areas. I like what Dr. Kezirian was saying about the emphasis on impact and the return to society, and we need to really stress how much it provides, because blindness really perpetuates poverty in the more remote parts of our world. But similarly, poverty really magnifies the suffering caused by sightlessness in those same low resource communities. So the big question, or one of the big questions, is how do we get the buy-in for sustaining care? Because in low resource settings, physicians want to live a good life. They've worked incredibly hard to become doctors. They've worked incredibly hard to become ophthalmologists. And how can we make it financially rewarding to them to continue to work in the poorest communities of their countries? And it's easy for us to come from the outside and say, yes, of course, you should be working in the poorest sections of Ecuador, up in the mountains and in the hills. But they still want to have their children going to the best school in Quito. And, it's a human question. I think one of the key things is to really engage the local community in terms of who is being trained. In Nepal, we've had a great deal of success taking, we have a 3-year program to train ophthalmic technicians after 11th grade. And we've been actively recruiting 11th graders who are gifted from the poorest and most remote communities and putting them into this training program. It's a 3-year program at Kathmandu University. And then they come back to their community and they become the leaders of primary healthcare centers. They are very adept at giving spectacles, grinding the glasses, providing some markup for medications, and they become financially sustainable and really well respected in their communities. Erevan does a similar thing, taking young village girls and bringing them in for 5 years of training. And instead of having them getting married at age 15, from 15 to 20, these young women really train. And at the end of their time, either they're more ready to go back and live a home life in their villages, or the gifted ones either stay on at Erevan or can go anywhere in India with a great job working as an ophthalmic technician. So I think part of it is really recruiting and empowering the people from some of these very poor communities, but figuring out how can we bring the economic incentive to continuing working in these communities. Particularly, as I mentioned, as the quality has been getting so good and the top doctors are able to make a very good living now in the more urban settings, to continue providing for the poor is a big challenge.
Thank you. So as we wrap things up, I just wanted to share a couple of different stories to kind of summarize lessons that I've learned from the field and share a little bit about what I believe is important in global ophthalmology. So I obviously still have a lot to learn, and I've already learned so much from the panelists. I hope everyone watching has too. But unsurprisingly, some of the most memorable lessons that I've had in global health weren't from big medical conferences or lectures like this, or even providing direct clinical care, though I have learned a lot from all of those avenues, but they really came from the mundane day-to-day human interactions that I've had and mistakes that I've made. So these photos are actually from Peru, where I was living when I was 19, working in this indigenous pediatric clinic. And my then best friend, now husband, came to visit me. We thought we'd go to Machu Picchu and climb Huayna Picchu. And it's not quite Everest like Dr. Tabin, but Huayna Picchu is just that majestic mountain in the back of the pictures. And as 19-year-olds are, we thought, easy piece of cake, we're going to climb this, no problem. But we were completely ill prepared. I was wearing jeans. He was wearing all white. We had no water. We had no food. And we made it, but we were completely humbled by the time we got down, and just reminded that things that look easy and seem like a piece of cake are not always a piece of cake. This is a great picture, but one of the earliest lessons I learned was that you need to quickly and humbly accept your mistakes, of which I have made many, many mistakes and will continue to make many mistakes as I navigate this world. So this photo is with my students when I was living in Bir, India, after undergrad teaching English. And on my birthday, the students gave me a bracelet that said Tibet, and I have really tiny wrists. So of course the bracelet didn't fit my wrist. and I wore it on my ankle as well. And I love eclectic jewelry. So I thought it looked really great on my ankle. And I thought I was just the coolest. And I walked into class the next day and I could immediately tell something was amiss. All of the boys were either laughing or like whispering amongst themselves. And I finally asked what's going on. And they told me that it was a huge disrespect to wear anything related to Tibet on my feet or on my ankles. So this was another great reminder that even with the best intentions in mind, cultural competency is a huge challenge for all of us. And the important thing is to really just accept your mistakes immediately, be humble, accept them with grace, and then move on and learn from them. And just know that you'll make mistakes in the future too, but what really matters is how you respond to them. I think this is a lesson that we often forget as we move through the hierarchy of medicine, but this is something that my mom really instilled in me early on, and that is that we need to learn from everyone that we meet. So this was the village that Lorenzo and I lived in when we were in Uganda. This was the first time that we lived without running water or without electricity. So we faced a lot of challenges related to that. But one of those challenges was washing our laundry. And once again, naively, I thought, washing your laundry in a bucket, how hard can it be? I can do this. And then I quickly realized that it's a lot more than just like dipping your clothes in a bunch of water and swishing them around and then wringing them dry and hanging them up. There's actually a whole method to it. And it took a lot of struggling before the women in the house kind of came out and guided me through the process. And, I was completely embarrassed at how inept I was at this seemingly simple task. But I think that this highlights two very, very important messages in global ophthalmology. Number one is that I think people sometimes glorify global outreach and global ophthalmology, and it's really not glamorous. You have to really, truly be willing to work in the field and to become part of these communities that you're working in. And then number two, and this is extremely important, is that you need to appreciate that there are just vastly different ways of living and doing things, and that we still have a tremendous amount to learn from everyone and every aspect of life. So know and respect your limitations. I think this one's extremely important for trainees, but also for all the way up to senior attendings. I sent this photo to my resident group chat, and the guesses in the group chat ranged from a gallstone to an actual stone. And then I showed my husband, who's an ER doctor, this picture, and he said, this is definitely a piece of charcoal. But I'm sure our panelists all recognize that this is an advanced cataract. We removed this cataract during an outreach trip in Cape Verde when I was a resident. And at that point in my training, I felt so confident with phacoemulsification. I was really at that stage where I was like, yes, I'm a cataract surgeon. I know this, I can do this. But then I saw these cataracts and I saw these patients, and I realized that I had very little experience in advanced lens pathology without phacoemulsification. And so I really had to step back and learn from my mentors and acquire this whole new skill set and be humbled in a way that, I had forgotten about at that stage in my training. And then this is me on that same trip serving as the scrub tech, the pre-op nurse, the post-op nurse, the circulating nurse, CPD, because no one really knew the instruments. They didn't have nurses trained in ophthalmology. So you really have to be adaptable and you have to be willing to go where you are needed as a global ophthalmologist. And of course, this one goes without saying. This is Dr. Pineda. He's one of my greatest mentors. I feel like I am only where I am today and have only become the person I am today because of the people that have supported me along the way. And that is especially true of my mentors through all stages of my training. I've been extremely lucky, and I believe that this is my last bit of advice. And that is really that once you get to a point where you are practicing global ophthalmology and you feel like you are a leader in global ophthalmology, you need to strive to become a mentor to others and strive to become an advocate for global vision health equity. And I want to end the presentation by saying thank you to the entire Rising Stars team and also to our expert panelists by sharing this mouth-watering photo of a Turkish breakfast spread, because I believe deeply that we express our human oneness through our shared love of food, as you can tell from this slide and also from my fun fact, I guess. And then if we have a few minutes, then I still do have some questions for the panelists. If they would like to share one lesson or story from their global work, what would it be? I don't know if anyone wants to go first.
Well,
Share.
I think I'd just say that, all ophthalmology is global ophthalmology. We're all on this planet together. And there are people who are in huge need of care here in the United States and all over the world. And just always remember that the patient you're with at the moment is the most important one on the planet. And whether you're in rural Uganda, whether you're in the mountains of Ecuador, or whether you're in Boston, the patient you are with is the most important patient you're dealing with on the globe. And everybody deserves the greatest quality of care and the greatest quality of compassion.
I think that's so wonderfully said, Geoff. I think that really, our goals and our mission is to treat, prevent, and cure blindness. And I agree, no matter what communities you're in, there's always going to be underserved communities. And really, our whole goal as ophthalmologists is to serve our communities.
I couldn't agree more. And there's an article that came out in 2021, in April of 2021 from the Lancet. It was on I'm going to get this hopefully right, the Global Commission on Ophthalmology Health, I think it was. But it's an incredible article that summarizes the entire corpus of literature from the last 20 years about public health and ophthalmology. And I recommend you look it up. Maybe we can post it with the video. It's something that's really quite insightful. What struck me about it was how much work there is to be done, not just in terms of the numbers of people, but things like Geoff was talking about. How do you define blindness? Is it 2200? Is it hand motion? Is it 2060? So this prevents us from having statistics, actionable statistics. We have to have the data. We have to be able to assess the impact of our work. We have to be able to tell our story in order to get the support, Sila, as you were mentioning earlier, to be able to get the financing and funding that we need to justify that funding because of the work and the importance of the work. So, there's a concept that dawned on me after working with Geoff Tabin for several years, and that is that I used to think about eliminating needless blindness. And I realized that, when the bucket keeps filling up, you're never truly going to drain it completely because there's always more being added. And so one of the concepts that's become, I think, pivotal for me to realize is that we have to look at the rate of decreasing blindness against the rate of blindness being added. And if we could have I envision this, I have this dream of this map of the world where there's green, where we're eliminating it faster than it's being created, yellow, where we're holding steady, and red, where blindness is still increasing. And if you paint the world with that map still, much of it's still red. It's much of the low income countries are still red. So this focus on data, I think, is important. On economics is very important. So you pointed out so many great aspects of this in your talk tonight. Thank you. My biggest take is that I think we've got a generation of people coming up with people like Sila in it who are going to solve this problem. Thank you for all the things you're doing.
And thank you, everyone. I truly learned a lot from each and every one of you tonight.
Thank you, everybody. Can we stop the share, Sila? Just a few notes before we close. I think it's been an exceptional episode because this is completely different from something that we've done before. And it really, Bill?
Yes.
We want to thank the sponsors, Allergan, Alcon, Vices, Dompe, Young MD Connect, Sun, Tarsus, and Avellino, without which, honestly, season 1, 2, 3 could not have happened. So thank you very much. But with Sila, I think in this episode, and to all three of you as well, Geoff, Guy, and Audrey, I think what you guys have discussed has completely shaken up the whole system. Because just give you a small background in terms of what you spoke about, and just a recap of the important points that I would take away from this. episode would be, you guys spoke about impact-based investing. That's huge, because that's one of the first things that people think about when they join this or any field. The second thing you spoke about was train the trainer, and that way you continue that legacy forward. uh, Geoff, you spoke about reaching them faster. I mean, how do you reach out to these people, and how do you get out there faster? Then, Sila, you spoke about public-private partnerships, which is going to be hugely instrumental going forward in the next 10 years, without which I don't see this completely changing. Then there is this need for constant engagement with major organizations that are spending money and not getting the impact what was actually predicted. And wow, Geoff, I didn't know that you quadrupled the training program in these countries where you went, and that's no joke, and that should not be taken lightly. And it's amazing work that's being done. And to the last point, which I think I'm going to take back, Sila, you said that this is not a glamorous field. It's all looks all hunky dory, but it's not a glamorous field. You got to really work hard to get there. And most importantly, I think the point is the personal satisfaction is huge. That is something that is unmatched in when you do global ophthalmology. So these are some of the couple of points that I think we'll wrap this episode up with. I think we'll give this as the highlight to everybody who wants to take up global ophthalmology, to contact the four of you to do a global ophthalmology. All right. But thank you very much, everybody, for being here, and for a really lovely episode. Thank you.
Thank you so much.
Thank you.
Thank you so much. Thank you.
Thanks, everybody. Great job, Sila. I look forward to